Welcome to Ellevate Louisiana's Health and Wellness Committee meeting. I'm Julie Stokes, founder and CEO of Ellevate. Before we start, I'd like to take a moment to recognize the co-chairs of this committee, Kathy Kleber and Cindy Munn. These women have been leaders in the healthcare space for many years and bring exceptional leadership and expertise. We're so grateful to have them guiding our committee again this year. For today's discussion, we're joined by Michael Bertaut and Dan Burke to discuss healthcare affordability. Michael Bertaut is the healthcare economist and exchange coordinator for Blue Cross and Blue Shield of Louisiana. He has nearly 40 years of experience analyzing healthcare policy and costs and was on the ground in Washington, D.C. during the negotiation of the Affordable Care Act. He has led thousands of public discussions on healthcare reform. He's a fellow of the Academy of Applied Politics at LSU. He also lectures at universities across Louisiana and authors the award-winning Straight Talk Healthcare blog. Dan Burke serves as Vice President of Corporate Benefits for Turner Industries Group, where he oversees the long-term strategic design of the company's total rewards program. With extensive experience in employee benefits and healthcare value strategy, Dan has led initiatives to improve quality and reduce costs through collaborative, outcome-based partnerships. He also chairs the Louisiana Healthcare Quality Forum and serves on the board of Taking Aim at Cancer in Louisiana. Thank you, Michael and Dan, for joining us today. We're looking forward to hearing from you both. So with that, let me hand it over to you to get us started.
Good afternoon, everyone. Like Julie said, my name is Dan Burke. I run the benefits program at Turner. We have 21,000 employees nationally, kind of spread across 30 plus states with a heavy focus in Louisiana and Texas, coastal Texas. Really happy to be here to talk to the Health and Wellness Committee. Kathy and Cindy, I know well through my work with the Quality Forum, and great leaders there, and I know that they're doing great work for Julie and her team at Ellevate. I want to talk about the impact of healthcare costs on employers and their employees. The most interesting thing to me here is that there's always been, with healthcare, it's occupied by multiple stakeholders with competing priorities, each with the power, political and financial, to stifle progress that could improve our system. But what I've always tried to do in my roles here at Turner and in previous positions around the US is try to find collaboration and win-win approaches for both the payers of healthcare, self-insured employers, and the providers in the community. So as we look at healthcare costs, behind payroll, healthcare costs are your number one expense. High cost strained resources that could be used for core business investment that holds down wages, and it can dampen business growth. And at the top, I want to say I'm not here to vilify anyone in the healthcare ecosystem, but we want to speak to the ways that businesses are impacted by these costs. My COO, David Franks at Turner, made a great comparison that I think resonates with business people about the impact of healthcare costs. As we educated him on the impact of costs on our plan, he came up with a good analogy. He said, okay, so in order to make up for an X million dollar shortfall on our health plan, we would have to win an X million dollar construction contract or an X million dollar maintenance contract. That really helps things resonate with our operations people. And that is important for them to understand it so that they can filter it down to the rest of the organization. And then employees bear a significant chunk of the cost as well through rising premiums, rising deductibles, rising out-of-pocket maxes, and it can impact other forms of compensation such as wages and retirement benefits. If you're squeezed on medical premiums, it's tough to really set aside 10, 12, 15% for retirement, your 401k plan. So the state of the healthcare industry today, looking at data from 2000 to 2024, you'll see a startling trend here. The numbers really speak for themselves. The average annual salary increased from 32,000 and change to just over 59,000. The average cost of family coverage skyrocketed in that period of time. from $64.38 to $25,572. And then the number of employers offering coverage shrunk from 69% to 54%. So the cost is increasing and access is shrinking, which is a grim picture. And we'll hit on some Medicaid conversation later in the presentation, but that's another factor as well where people are beginning to lose access to healthcare. So I've had the opportunity to contribute claims data to the RAND Corporation study over the last 5 years. And this is a study that compares, it benchmarks commercial health plan prices to Medicare, just as a benchmark. It's important for employers to have a voice and contribute data to this study. I'm not here to say that employers should be paying Medicare rates to hospitals and providers, but the 254% that you see here on this slide is probably a bit too high. Maybe 125, 150 could meet those needs. And this is, for employers, it's a massive hidden cost that we are bearing. Hospital services represent the largest share of total healthcare costs for privately insured Americans, making up 37% of that total. And the cost pressure has a direct impact on employees. Financial and physical well-being, mental well-being, that's a factor as well. A third of Americans have to take out a loan to pay for medical expenses. That's just crazy to me. It's stunning. 52% of Americans feel stressed about medical bills, and that stress is impacting their health, as I referenced earlier. So, the RAND study brings some of these things into light, and we have a couple of slides to hit on some of that. So here we're seeing the medical debt from the weight of medical debt and the impact that it has in Louisiana. 22% of state residents face medical debt, and collectively, residents owe nearly $2 billion, an amount larger than the budget for the city of New Orleans. Just staggering. And the Louisiana ranks in the top 10 states for the states with highest medical debt, with an average of $2,150 owed by its citizens. And I talk to people every day that are in a dire financial situation, largely driven by medical debt. People that are out on a medical leave, getting care, don't necessarily have a paycheck coming in while they're getting care. And meanwhile, they're getting bills from providers looking for their deductibles and co-insurance. It's not a good state of affairs.
I was listening to a discussion this morning online about medical debt and whether it's counted in credit scores, and how states are starting to enact policy that medical debt shouldn't count in a credit score, and whether or not they can really do that state by state, and it doesn't have to happen at the federal level. Have we ever tried? Do you know if we've ever tried to do anything like that here?
Not that I'm aware of, but I would be fully supportive of that. And
Yeah.
folks that have and carry medical debt for periods of time, have other financial pressures on them as well. And if they're not able to receive loans or the money that they need for their purchases, that's a severe issue. That's a great question.
Yeah, because it's, and they mentioned that it's not voluntary spending. It's not that you went out and got yourself a bunch of expensive things. You literally got sick or
Yeah.
something happened to a loved one. Anyway.
Well, and exacerbating that is the proliferation of high deductible plans and people that are trying to manage their week-to-week premiums by taking a plan that has high out-of-pockets. Meanwhile, they can't use it, so they're functionally uninsured.
Yeah, a lot of people with $30,000 maximum out of pockets, and it's like, oh, it's a
Yeah.
lot.
So in this slide, since I've done this kind of work, I've been doing benefits management work for 30 years. And the term most often used in reference to healthcare cost inflation in that period of time has been unsustainable. And, by definition, it is not unsustainable. If you continue this inflation year over year, what it is not is supportable by the facts. So as we go through this presentation, you'll see some resources and some information that will bring that to light. So as we look at this slide, you'll see costs are growing 4 times faster than wages. Premiums as a percentage of income is skyrocketing as well. Deductibles have increased by 473% since 2000, and premiums by 355%, while wages only grow 178%. Something has to give. And at some point in time, we'll see what that looks like. All right, so this looks at medical cost trend and 60% increase in family premiums for employer coverage over the last decade. PwC does a study each year that I follow closely. All these consulting houses have them. PwC has been a consistent one for me, so I tend to use that most regularly. The cost trend is at 8.5% for 2026, much higher than we've seen over the last 5 to 10 years. It generally resides in the 5 to 6.5% range. The forecast here is not good looking forward. The average total employer coverage premiums are projected to hit 26,000 this year. And when you look at the rise in the worker contribution as well, almost $7,000 in contributions, just eating into paychecks. Analysts just see no end in sight for this trend, which gets back to my comment on the last slide about the inflation trend's sustainability is just continuing on, and there's really nothing that can be done to stop it in a broad scale. Now, there are strategies that employers can put in place to manage their populations better, be a better steward of their company money and their participants' contributions. We can get to some of those coming up. I love this slide. This chart is just staggering. As a person who has a college sophomore, number 2 on this list, you see college tuition and fees as price changes from 2000 to the current to 2022, I think. Yeah, December of 2022. But the only one exceeding that are hospital services. So they increased 227% in the last quarter century, far outpacing medical care services overall, well beyond the 76% inflation rate. This evidence suggests that price is the problem, not utilization. And, like I said earlier, we don't mean to vilify anyone in the healthcare universe. Employers have been culpable in what we see here when it comes to not just hospital services, but healthcare services writ large. Many of us have abdicated our responsibility to consultants and brokers to interface with health insurance companies and PBMs. We just need to be more engaged as employers to have a voice and a seat at the table to try and make a difference, try and advocate for positive change. I'll talk at the end about the Employer Coalition of Louisiana, which is a really exciting organization that Cindy and I have built over the last couple of years. And it's promising into the future. And that is a way for employers to amplify their voice to be able to represent their interests. This shows the national map as you consider the RAND hospital cost study. This really underscores the price problem. Commercial plans pay 254% of Medicare. In Louisiana, we're a little better, 239. But look at Florida, 344. We have employees in Florida. Texas is at 259. We have employees in Alabama. We have employees up north. We're actually adding almost 1,000 employees in Indiana in December. They're at almost 300% of Medicare. So that is a staggering number. We're just paying dramatically different prices for the exact same service, depending on where we're geographically located. And, it's remarkable that you think about all the retirees that are in Florida. They're getting Medicare reimbursement, right? And the commercial plans are paying 344% of that number. So that's a staggering number.
So why? Why is it so much different from Florida, the employers are paying 344%, but in Louisiana it's over 100% less, 239%. And in Arizona, though, it's only 164%. Is that to do with how many people are on Medicaid and Medicare, or what gives there?
I think you're trying to apply reason to an irrational market, Julie.
Okay.
As you look at healthcare, you think about some of the industries that have been impacted by transparency when it comes to cost, right? Travel, that's one. And back in the day, you used to have to call a travel agent, get your airline ticket. Now you go online, you find a price. Same with hotels. That doesn't really exist in healthcare. and the providers have taken advantage of that opaque market to be able to put the markups in place. Fortunately, most employers have partners like Blue Cross Blue Shield, United Healthcare, Aetna, Cigna, the insurers that have negotiated rates down. But as you can see here, they're not down far enough. So these pressures exist, and it's just a crazy number. This just goes into hospital markups by state. So this is an alarming number. Louisiana's at 627%. And again, Florida's at over 1,000%. Nevada's at over 1,000%. Just a crazy thing that is just difficult to justify by the facts. You know, it's because they can, it's not because it's rational.
And it seems like that they get squeezed out, from having worked at a major hospital system at one point in my life, albeit a long time ago. I can remember that Medicaid was paying such a low percentage. Medicare was still paying a low percentage, and that's kind of become the standard, that we measure everything by. But then, that left private pay or people that were in insurance products to make up the difference.
Yes. And you think about it, one of the tools that we'll look at here in a couple of slides is the SAGE transparency tool. That allows you to look at hospitals by region and look at the RAND numbers in terms of cost. It has quality information. It refers to the hospital system's tax filings to determine what their break-even point should be in terms of a percentage of Medicare. And those are all over the board too. Some health systems are really efficient and can make money on Medicare, but most of them do shift costs to the employer and private sector to make up for the differences that they can't make in Medicare. All right, so if you've ever turned on a TV in the last quarter decade, you're bombarded with prescription drug ads. So a big cost driver for employers is prescription drug market. Huge portion of drug costs, 60 to 65%, are driven by a small number of prescriptions. That's exacerbated by financial incentives and perverse incentives, I would say, that are in place for pharmacy benefit managers, PBMs. And there was some legislation proposed last year, Julie, about PBMs limiting the access, PBM's ability to operate, or pharmacies' ability to operate in the state if they own pharmacies. So CVS Caremark is one, and that actually happened in Arkansas, and CVS is really stepping back in that state. Really, at the end of the day, PBM's incentives, and this is a common thread across the healthcare ecosystem, incentives just are not aligned with the employers purchasing the coverage and the patients that are carrying that coverage. So you'll see these fees just drive up costs overall. And quite often you'll hear about rebates. So self-insured employers often enjoy rebates on high cost drugs, which will lower your net cost. But to me, pharmacy benefits are the ultimate shell game. It's even less transparent than the rest of the market.
Well, and it looks from way back here, it does look like the pharmacies themselves are kind of getting squeezed out, because I noticed that the level of service that you get at pharmacies has just really dwindled. And they've got to be having trouble meeting their margins because the PBMs are taking some of the air out of the room. We just, our last, well, actually, it was in our cancer advocacy committee. We did a show or a discussion on PBMs.
Yeah, and you see it when you go up to CVS or Walgreens, any of those. You walk inside to pick up your medication. They've got candy there, they've got magazines there. They're hoping you're going to buy the other products there to help make up some of those margins. High cost medications and therapies. So this is something, Julie, you and I were talking about stop loss insurance before the start of the program. One of the things that employers will do to protect themselves against gigantic claims is purchase stop loss insurance. So claim over X amount of dollars, whether it's 100,000, 500,000, $1 million, you can set your own threshold. We'll have insurance on top of that to protect the plan. But what you're seeing is that the emergence of these life-changing yet staggeringly expensive treatments like gene therapies is a major factor in costs. These gene therapies are really, they're once in a lifetime treatments. And some of them, and you look at the top one, Casgevy, 2.2 million. You've got a $3.2 million in there. What we've seen most frequently in the employer market on my side, and Mike might have some insight from the large health plan side, Roctavian or Hemgenix, which both treat hemophilia, they're over $3 million. Zolgensma is a drug that is essentially curative for spinal muscular atrophy, 2.3 million. It's they're expensive because the potential pool of patients is so small. These are really rare diseases. But like I said, they're largely curative, and the manufacturing is complex and costly. So the manufacturer has to recoup their costs. Also, cancer treatment. Can't any employer, 8 of their top 10 most expensive claims will likely be cancer treatment, unless you've got gene therapies in there. And the evolution of cancer treatment has gotten to a place where we couldn't have dreamed of 20 years ago. But there's a cost that comes with that, even though that people's lives are being improved and extended by the efficacy of those drugs. It's just, you have to balance one with the other.
Yeah, and I've been involved in that space a lot, and it's just so hard when there's something out there that can change a person's life, save their life. Think about hemophilia. I mean, change somebody's life entirely. Cancer saves somebody's life, and it's a real hard thing to say, well, it's just too expensive, and then everybody looks at what they're paying in premiums, and it's like, we have to get these drugs for people. It's a hard situation, and the rare diseases are especially because, like you said, there's just so people with it that it gets not enough people to split it out between.
Right.
And to be fair, several of those manufacturers of the gene therapy drugs have guarantees on the drug where if it doesn't produce the desired effect, you pay a lot less. Or in some cases, a fraction of what you would pay otherwise, because they want to encourage people to cover them.
Yeah.
Also, some of the carriers have created, even for self-funded groups, small risk pools on the side, so to speak, where for another couple of bucks a month, you can buy into coverage specifically in case this happens to that group. So at a nominal cost, because like Dan said, they are very rare and they cost billions to develop, and you just don't have a very big pool of people who can actually utilize them. But the idea of some of these drugs, I think about Zolgensma, for example, for spinal muscular atrophy. That's a disease where the average lifespan is about 17 or 18 years old, and that's it. And sometimes when people get this drug, it provides a genetic replacement that's curative. And I mean, that's huge. It's technology we always dreamed would exist. We just didn't think about how much it would cost when it was all said and done. But it is pretty amazing to me.
It is. Thanks for
I
that, Mike.
wonder if it'll be like, I'm sorry.
Go ahead. Go ahead, Julie. No.
I was just going to say, I wonder if it'll be like when you had your slide up that talked about the cost of different things. Maybe someday it'll be like TVs, and we'll be cutting the cost of it. I would think it's going to have to go down a lot because the technology just gets easier.
It does. And that's a great example. TVs, when the flat screens first came out, they're $1,000, $2,000, depending on the size. Now you walk into Target, you buy one for a couple $100.
Yeah, 85-inch.
That's right. And the other factor that isn't included on this slide, it's gotten a lot of press, the GLP-1 medications for diabetics and for weight loss. You've got the Ozempics that are really targeted for diabetics, but then you have Wegovy that's there to treat folks with weight loss. And that's been incredibly well received by doctors. Any doctor I've spoken to about them consider GLP-1s to be a miracle drug, because not only are you effectively treating diabetes much better than you ever could, but for people losing the weight, their health risk, cardiovascular risk down the road is significantly impacted by that weight loss. So that's another thing that employers deal with in trying to determine how to handle that.
And addictive processes too. I mean, it really helps.
Yes.
Yeah, exactly.
All right, the 340B drug pricing program. This is a bit down in the weeds, but as you look at this, the 340B program is a federal program in which manufacturers provide a heavily discounted drug to qualifying hospitals and clinics, really meant to serve low-income and vulnerable populations that would not be able to afford those medications. And really the purpose of this is developed with the best of intentions. But over the span of the last many years, the program's growth really shifted costs to employers and employee insurance premiums. Because these facilities can purchase drugs at a discount and provide them to patients that are generally low income, but when they have a surplus of those medications, they can provide them to people that are not low income under the 340B program. And this is one that has really gained a lot of attention nationally. Senator Cassidy has brought it up recently. That's something that he's passionate about and is talking about. But this is something that health systems are doing. I don't think it was the intent when they put it in place, but that's where we're at. Pharmacy growth. You're looking here that pharmacy growth is forecast to outpace medical spend. It sits at 3-to-1 today, but in the future, it's going to be 50-50. We don't know how far in the future that will be. And it's just remarkable. And the gene therapies, the medications that are continuing to be developed day by day, that again are life-changing, but they do come with a cost. So we will get to a place where it's 1-to-1 and probably not far in the distant future. One big beautiful bill. All right. So what is the impact here? It's really hard to say. It's still kind of early in the process. I think the fear that a lot of employers have is that people coming off of the Medicaid rolls as a result of one big beautiful bill will result in those folks coming onto employer plans, potentially driving up the cost. It may be good risk that joins our plans, and it won't drive the cost up. However, that is a concern in our business. And then the consultants of the world are projecting employers to see a 10% jump in costs as a result of that. Again, this is all projection. We haven't seen it yet. And then the loss of public coverage, again, that's an issue. There's a lot of work to be done on this. So this gets into nerdy benefits HR speak, but at the end of the day, employers play a critical role and have a fiduciary responsibility to act in the best interest of their covered employees on their health plan. The Consolidated Appropriations Act of 2021 has really put an increased spotlight on that fiduciary duty. It's always been there, but this act has put a focal point on it. If any of you have been in the retirement space, retirement planning space, back in 2007, 2008, the federal government put a similar fiduciary duty focus on retirement plans, looking at fees that are charged to participants in retirement plans, looking at investments, and really coming after employees for the decisions they're making for their employees. And that's what we're going to see on health plans. And that means that employers are now required to ensure that they're paying fair prices for services. But as we've said, we don't really know what a fair price is based on the information available. So that fulfilling that obligation is really challenging. And back to my parallel earlier, refrigerators, buying a car, you can look online and determine what costs are, determine what quality the item is that you're purchasing, and make a decision based on that. And healthcare is not a rational market, but it's difficult. So after the CAA, lawsuits are happening. You had one with Wells Fargo. Johnson & Johnson had a lawsuit filed, and there are attorneys that are experienced in ERISA law and coming out and putting up ads like the one that you see here, saying, are you an employee of, in this case, it's Target. who participated in the company healthcare plan. That's really scary to me. This is a litigious world, and these attorneys can come with a class action suit and really put an employer in a tough spot. Not to mention regulatory agencies, DOL. Turner had a DOL audit that extended from late 2019 until early 2023. No adverse findings, thankfully, but that was a process and a lot of additional work that was not on my calendar for a period of 3.5 years. All right, I referenced this Sage Transparency. This is a free public-facing tool. It will give you an idea of hospital price, cost, and quality data. The data shows that the variation in price is wide from facility to facility. And without spending too much time on this slide, I would just encourage everyone on the call, when we're done, go to Sage Transparency, just Google it. You can go in there and look at costs based on your location. And this really gets into the idea of price variation based on different things. And these are the one I like looking at because it's a common procedure is in the second table, the coronary artery bypass graft. You've got a Medicare reimbursement. You've got a price in the Baton Rouge region, and it's 2.5x what the Medicare price is. And then you've got potentially a savings of $53,000 if you have a reference-based price, which I'll get to in an upcoming slide. At the top, imaging is another big one. And we've tried to educate our employees on the importance of shopping around to the extent that is possible to find imaging if you need an MRI or CT scan. What it will cost you in your orthopedist office is going to be a lot more expensive than if you went to a freestanding imaging center. And we provide incentives for folks to do that. All right, so what can employers can do? That's a lot to unpack, and I'll kind of jump into some ideas here and then wrap it up for Mike to take the stage. So one of the things that I referenced earlier was reference-based pricing. And what that does is an employer will partner with a TPA or a firm that can administer claims for their plan, and it will cap reimbursement at a percentage of Medicare. For example, 150, 200% of Medicare, no matter where anyone goes. And the payment will either be accepted by the hospital or doctor's office, or they will balance bill a patient. I would love, my inner curmudgeon would love for this to be a viable solution for my population. But at the end of the day, I really worry about potential balance bills to my people who have financial struggles, like any population. And if the hospital doesn't accept that payment, they will balance bill a patient. One other piece of it, though, is that a lot of these health systems are used to chasing money. And if you pay them in a timely basis on reference-based pricing, sometimes they'll accept that reimbursement at 200% even if they usually get 230 or 240 from a commercial insurer. But again, that's the nuclear option as I look at it as an employer. The other is high performance networks. The insurers all over the US have this. Mike's organization have Quality Blue, where you can have a network that is channeling your employees to high performing providers. United Healthcare has a Surest program. It's known as Surest. It was Bind, and then United Healthcare bought them, and now it's Surest. And that sets copays at a different level based on the quality and cost of those providers. So that is one way to potentially meet those needs. Next slide. Then we have direct contracts with health systems and providers, really labor intensive. For example, Turner, we're across the street from Our Lady of the Lake. We have a very close relationship with the organization. If we were able to negotiate a direct contract with them to provide benefits to our folks, that could be financially beneficial. If you can provide volume, it makes sense for a hospital to enter into that kind of arrangement. But again, it's tricky. You're going to have to get a TPA to administer that. They don't administer things as well as the carriers do, like Blue and United and Cigna. It just becomes a heavy lift administratively for an employer. Copay waiver partnerships, that's something that Turner does right now. Trying to remove barriers to care in certain markets. We have a partnership with Lake Urgent Care where our people can go into their urgent care centers and we'll waive copays on certain plans that we offer. And again, it's about access, removing that financial barrier, even if it's $25 or $40, that can be all the difference. Centers of excellence. This is the ability to steer care to specific procedures to facilities with best outcomes, right? So you think about if you need a joint replacement, you want to go to someone who's doing 100 of those a month instead of someone that does 3 a month. And you can do that in a bundled pricing arrangement rather than a fee-for-service arrangement where you get a bill from the facility, you get a bill from your surgeon, your anesthesiologist, your PT. You do it in a bundled fashion rather than that fee-for-service environment. We are heading down that path in 2026. I will let you know how that works out. It's my internal reputation is staked on to the success of that program. And then advanced primary care. This is something I believe in quite a bit. This uses a capitated model to offer access to primary preventive care at little to no cost for patients. Basically, you pay a monthly membership amount to a provider to give access to your employees. We've done it in Houston to about 3,200, just shy of 3,300 people in that market. And it's lowered our healthcare costs about 19% year over year for that population. So these are people that are going in for their checkups. They're going in for managing chronic disease. They're also going in for a bone break or a sinus infection or a sprained ankle. We're seeing some good things from that. Just really excited about the growth of that kind of thing and the importance of primary care, because our employees travel the US. They are generally not savvy when it comes to using their healthcare. And if you can get in front of them and say, you can go to these places for free, they're going to take advantage of that, which ultimately has some good downstream impact. All right, next slide. I think we're open for questions.
Well, I have been looking at some information on Turner Industries, a company that I often see the name and I've heard of it, but you guys are pretty interesting. And so this is your job to try to manage how healthcare gets delivered to your employees and try to bring down costs and look for opportunities to find quality and constant care or good primary care instead of waiting until after the primary care hasn't been gotten. Yeah, it's very good.
Yep.
Very good.
Well, thank you, everyone. I appreciate the time today, and I'll stick around for questions.
Yeah, because there probably will be some, and we really appreciate it. And it's been a pleasure to learn more about Turner and just what you guys are trying to do with your 20,000 plus employees.
Hey,
Yeah, well, thank you.
can I ask one quick question?
Yeah, of course.
Now, Dan, your thoughts in terms, I mean, I know, it's really scary to me first of all, when I look at how these prices have increased over the last 10 years. What do you think also the Medicaid expansion and having a higher Medicaid population has again made hospitals have to compensate even more because of that? And again, I want to be clear, I'm very much in favor of Medicaid expansion, but I do wonder if that has also changed again when the hospitals are dealing with lowered payments and Medicaid being it used to be a significantly lower than Medicare rate, that may have also affected the hospitals and then having to charge private insurers even more.
Yeah, I will defer to the economist on the call, but anecdotally, I would think that probably had an impact. And I'm with you. I support Medicaid expansion is necessary in a state like Louisiana. But yeah, I would imagine that resulted in cost shifting.
Yeah, there's some pretty strong evidence that a significant portion of your private health insurance premium is made up of the shortfall that between what Medicaid pays, what Medicare pays, and what the wholesale cost of delivering medicine really is. At the facility level, it's very noticeable. At the specialist level, it's also quite noticeable. But specialists always have the option of limiting the number of seats that they offer to Medicaid or Medicare patients. Whereas an acute care facility, if they've got a public facing emergency room, they can't really control their patient mix. They're going to get what they're going to get. And not unusual for 50 to 65% of the beds in any particular Louisiana facility having a Medicaid or Medicare patient in it on a day-to-day basis. That's not unusual.
All right, so let's go ahead and hear from Michael. I'm excited to hear your information too.
Yep, I'm gonna kind of bring things a little more boots on the ground to Louisiana with some data that we observe that I hope can shed some light on how the insurance, the healthcare marketplace has changed so radically over the last couple decades. One of the things that's always fascinated me is, as an economist, we kind of have heroes, guys that we follow that we really appreciate their perspectives and their research and what they've had to overcome to get to where they are. And Dr. Walter Williams has always been a hero of mine. And I saw him back in 2017 at an event in Nashville, and he was commenting on healthcare specifically. And he said this, he said, look, one thing we've done magnificently in America is we've managed to build a world-class, technologically advanced healthcare system that's the envy of the world. People come from all over the world to get cured here. But in the process, we forgot to make it affordable. We forgot to make it something that the average American could pay for out of his own pocket. And so now that means we're all entirely dependent on a third party to pay for our health care, whether it's an employer or insurance company, Medicaid, Medicare, the VA. Somebody has got to cover us when we get seriously ill or we don't get access to the latest and greatest treatments and care that we need to get well. And I think we have to kind of keep that in the front of our mind as we look through problems versus solutions going downstream. This is my view of Louisiana as a collection of third-party payers for healthcare today. There is no, I will tell you right now, people do surveys, they do estimates. There's nowhere you can go and look this up and get a snapshot that's relatively accurate. But we can back into some of these numbers and make it pretty accurate. I redo this exercise every summer. I did it a couple months ago. This is what I came up with. And you'll notice Medicaid is about a third of the population, and about 16% of the population are seniors on Medicare and disabled folks on Medicare. If you throw another couple of percentage points on there for people who are in the VA or on other government programs, what you find is Louisiana has more than half of its population accessing healthcare below wholesale cost. Below wholesale. Now, that's not a surprise when you consider our poverty level. Louisiana is about the poorest state in the nation in terms of household income. But what it does is it puts enormous amounts of pressure on the healthcare system to find revenue somewhere else, which they often find from your employer or from your insurance company if you're buying private coverage. Also worth noticing, at 9%, which is my current estimate of the uninsured, prior to the Affordable Care Act, that number was in the 20s. Prior to us expanding Medicaid in 2016, we would count that uninsured number around 22%, 23%. So that's, no matter what the ACA has cost, and it has cost a lot, that's a clear societal good that we need to acknowledge that the Affordable Care Act has created here in Louisiana. This is doing research on the average hospital cost, what wholesale costs are, and getting meaningful results is extremely challenging. But Colorado, a few years ago, decided they wanted to get into the insurance business and create their own public option health insurance plan. So they did a 3-year study on hospital costs and outpatient costs, doctor visit costs, versus wholesale costs of providing those services for Medicaid, Medicare, and private insurance in their marketplace. And so what you're looking at is their estimate, and I've compared that to the data I have from Louisiana, and I frankly don't find any big difference. So I'm comfortable saying Louisiana is very similar to Colorado in this measure. So if you look at the first 3 bars, imagine that someone has a hospital stay. I go in the hospital for a cabbage, let's say a bypass, and the hospital tracks everything they do to me, and they keep a whole count of the wholesale costs, the actual cost of getting me well. And when they discharge me, they decide that it cost 100 grand to get Mike back up and on his feet again. The question then becomes, how much of that 100 grand are they going to get back when they bill Mike's third party provider? And the answer to that question is, who are Mike's providers at the third party? If it's Medicaid, Colorado found the hospital was getting about 56% of wholesale back. In other words, they were losing more than 40% every time they touched a Medicaid patient. For Medicare, it was about 70%. So they were losing on average 30 points of margin every time they touched a senior on Medicare. And the private insurance companies were being asked to pay about 35 points of margin to compensate for that, which you can see is roughly 200% of what Medicare was paying at that point in time. If you look over to the right, you can see a similar comparison for all fees means doctor visits. So like a specialty visit or a primary care visit. So we always want to make sure that we're cognizant of the fact that when our employer pays a premium on our behalf, we contribute to that premium, or we buy an individual policy, that we're not just propping up the risk pool that we're in, we're also propping up Medicaid and Medicare at the same time. Go ahead to the next slide. If we go back in time to when the Affordable Care Act was passed, one of the things that changed that people still can't wrap their brain around, but it controls our industry, is that we are now required to guarantee to the IRS every year that when we accept a premium dollar from a member or an employer, that 85 cents of that premium dollar bought nothing but health care. So in other words, our gross margin, how much we operate on, is capped at 15 points of margin for our largest clients. At the end of the day, what that means is that you can be comfortable that of the dollar that ends up in Blue Cross's coffers, 85 cents of that dollar is buying nothing but healthcare. In fact, last year it was more like 86 cents on the dollar. And so when we talk about, well, Mike, what are you doing with the 15%? That's where you pay for everybody's salaries that works for the company. We're a tax paying not for profit, so we got to pay taxes and Affordable Care Act fees, which is a percentage of premiums on top out of that 15%. We have to pay commissions for every agent, broker, or consultant who does business with employers in Louisiana. They get paid out of the 15%. And then hopefully, when it's all said and done, we have a point or two left over to put in our rainy day fund, because we are not giving money to shareholders. We have to maintain a bank account that can cover all of our costs for 2 or 3 or 4 months with an interruption in income. And Katrina kind of led us to that, where the regulator said, man, we never considered the fact that you might have huge blocks of people that you had to keep insuring that couldn't pay you. So we have a little bit more money in the bank now, percentage wise, than we had pre-Katrina, because of the changes in the way that's managed. The other thing to remember is this 85-15 rule has led giant insurance companies, large publicly traded insurance companies, have realized that they can't really squeeze out enough profit to keep their shareholders happy out of the 15%. So what they did is they took their excess capital and they bought into the 85%. So they looked at, where am I, all this money I'm taking in, where's it going? How can I be a recipient of that in a market where there are no caps on margin, right? Hospitals don't have margin caps, drug companies, PBMs, pharmacies, doctors' offices, they don't have to live in the 15% world like insurance companies do. So you see the giant insurance companies own home health agencies and clinics and PBMs and all kind of stuff. Well, the strategy is real straightforward. Those are the areas of healthcare spending that aren't capped by federal law. Only the insurance operations are. And so when you see these huge insurance companies getting very vertically integrated, that's the strategy. It works. That's what they're doing nowadays. Go ahead to the next slide. I don't want to make you guys late. 20 years ago, when I joined Blue Cross, if you took $1 and tracked it through our system and said, Mike, where did that dollar go? This is where it was going in 2004. So we took in $1 a premium, 38% of that money went to pay an inpatient hospital bill, 34% of the money paid for outpatient or physician services. 11% of the money bought drugs. In other words, we could cover the prescriptions of all of our members, hospital costs for drugs, doctor office costs, pharmacy, for 11 points on. And back then we would take 17% to run the business. We didn't have the 15% cap way back then. I'm going to take you forward to last year, and you're going to see some pretty dramatic changes in the way the money is spent now. Take a peek at what's happened between drugs and physicians compared to 20 years ago. Notice hospitals are still getting 34 cents on the dollar. That's pretty close to their original 38. Outpatient docs, clinics are getting 20 cents, 20%, and they used to get in the 30s. And drugs are consuming 32% of the money that came in the door in 2024, basically triple what we had to spend on drugs 20 years ago. I also want to point out that 20-year ago slide was on about 2 billion in revenue. This is on 5.5 billion in revenue. So not only is it a bigger percentage, it's a lot more money. And you'll notice that we're well within the 85-15 rule last year. We were at about 14% overall on our overhead category. One of the things that is driving drug costs so high, you heard Dan mention GLP-1 drugs. We have discovered that for type 2 diabetics, GLP-1 drugs are very, very valuable and essentially worth the cost, even though they're $800 or $900 a month when somebody is a type 2 diabetic. If somebody's just obese and they want to lose weight and they're not type 2 diabetic, haven't had a heart attack, haven't had a stroke, the pricing doesn't make any sense. You're essentially applying a $1,000 a month solution to a $200 a month problem. And so the conversion from obesity to diabetes, number one, is not well understood. Number two, it's impossible to predict who is going to be converted. There are risk factors, but that doesn't tell you who to target. And the third thing about that is currently, you can see from this slide, America is being soaked by the drug companies on GLP-1 prescriptions. This is what an average month costs everywhere. To the right is not America. The slide, the bar graph all the way on the left is what we have to pay for Wegovy or Zepbound currently in the US. That's pretty close to what we actually pay after rebates for those drugs. So you wonder why insurance companies won't cover for obesity is because it literally makes no financial sense to do so. And the benefits are so long-term in the average obese person that an employer would be highly unlikely to have that person on the books before they derived any financial benefit from providing those drugs. Also, of the 31 blue plans that are out there operating, 9 of them lost money last year, billions of dollars. And every single one of the 9 mentioned that they were covering GLP-1s for non-diabetic weight loss, and it ruined their finances. It was crazy. So you won't see us being in a hurry to cover these drugs until the prices are rationalized around $250 to $300 a month. We'll be all over it. At $800 or $900, there's just no way. We advise employers. We don't tell them don't cover it, but we do give them a realistic 3-year estimate of what will happen to their cost if they do.
On that, I mean, if you use the rare disease medicines that we were just talking about in the previous presentation, and you know, in the United States, we've got tons more obese people than you have in those other countries generally that were on your graph. And so there's so many people spread it out between why are they charging us so much for it?
Because very important, everybody pay attention, because they can.
Right.
That's it. There's no magic there. As an economist, I would love to give you a big algorithm and a formula and a white paper, but the reality is they have the freedom to do so, and people are paying it, so they're doing it.
Cool. So not cool, but cool.
Yeah, that's okay. You're going to hear a lot of debate over the last month about the advanced tax credits on healthcare.gov. The Dems have said that's why they shut down the government. They want that extended. The Republicans have said open the government and we'll talk about it. This is Louisiana's reality, what the change would look like for a select population if those tax credits at the enhanced level. Now remember, tax credits aren't going away. We had an original grid in the Affordable Care Act that told us how much to fund tax credits for insurance. And then in 2021, they added a huge, generous portion on top of that. We're talking about the generous portion on top being removed, not the actual tax credits themselves. But even the removal of that generosity would have this impact on these select populations in Louisiana if they don't fix it. I want to make you aware of what our thresholds for Medicaid will be this year. So for an adult, an able-bodied adult in Louisiana, the left-hand column is the income threshold for Medicaid eligibility. Anything below that is eligible, and they will be checked twice a year starting next year. So you want to make sure people who are Medicaid eligible keep up with their paperwork, or they will get booted. If it's a child age 0 to 19, we're much more generous. You can see the household incomes on the right. Children are covered in all of those households that you see to the right there. So those are going to be the Medicaid eligibility thresholds going forward for the rest of this year and most of next year as well. That's the only thing I brought. I just want to admonish you, encourage you not to let change scare you, right? We're all going through change. The pace is terrifying. That picture you're seeing there is my kitchen a year ago, right? Literally the actual kitchen of my house that my wife designed in 2003 and 4, and we built 20 years ago. And she came up to me about a year ago and said, she retired, RN, 35 years in nursing, right? She said, I hate this kitchen. We've got to remodel it. We need to do something. I said, fine, whatever you need, we'll make it happen. About 3 weeks later, I came home and they had demolished all of this. And so it was just dirt and cracked up floors, and it was horrible. I walked in and I went, we have made a mistake. This is bad. And she came over, you know, she loves me. She held my hand. She goes, Mike, I got it. It's going to be all right. And I looked down at her and I said, you are crazy. And that's not true. I didn't say that out loud. I said that in my head. And she was crazy. And sure enough, 3 months later, it was glorious. She was right, just like she's always right. Look at the last picture. That's my kitchen now. After my wife calmed me down and got it all done. And so I'm just telling you, change is scary, but sometimes you end up way better off by going through it. And that's enough. Poor people. Make you
So
late.
what's the change? What should we do? What do we do to change it?
Well, I believe that Dan is on the right track, that you can, what you need to do if I'm an employer, I need to identify where my biggest gaps are and identify something that'll fill the gap. Now, you'll run across no shortage of consultants and whiz bang guys with a fancy website and an app who'll tell you I could fix that problem. But what you really want to do is to talk to other employers who've actually achieved something in that area and find out what they have to say about it. So like if I wanted advice, if I owned a big company and I wanted to know and I was having a particular problem, I wouldn't call Joe the consultant, I'd call Dan. And I'd say, Dan, you've got this experience in this big company. Has this worked for you or not? Because Dan would love nothing better than to get as many people as possible on board with what he's doing, because the more people that do it, the cheaper it'll get. And the easier it'll be to leverage people and get a better deal. So
this is a good place to put in a shameless plug for the Employer Coalition of Louisiana.
Yeah, absolutely.
Cindy's development of that. Mike has been a speaker at our events. I think we're generating some momentum and at least some intellectual conversation with peers about these kind of approaches has been effective. We had a session 6-8 weeks ago where an MD sat down with a group of us that are members of the coalition and went through our high cost claims and identified areas to look at, identified areas to try and manage the impact of those high cost claims. That's just one example, but it's really about collective influence, and Mike's presentation is always great and certainly appreciate that. I love the slide that you have on there with the dollar. It's always, it's so enlightening.
Well, Louisiana is not exactly like every other state. And so I really want people to see who's got the stick when it comes to demanding money in the healthcare system, right? And right now it's pharma. Pharma has the stick. And so we buy $1 billion worth of drugs a year in Louisiana, Blue Cross, $1 billion, and we're nobody in the drug negotiation business. It's a $900 billion industry. So I can't say, hey, I bought $1 billion worth of drugs. You need to give me a better deal. They're not really paying that much attention when I do that. So it's something we have to understand and moderate as we go forward.
I just want to thank you guys. It's been such a pleasure to get to know both of you and to hear, your take on this enormous issue. And I can't help thinking, Michael, it's like, what did you do to solve the problem? You just took the whole thing down and started over again. But I mean,
Well, you
nothing's
know,
that simple. But
Julie, no, you're onto something because if you look across the globe at all of the countries that have centrally managed health plans, none of them volunteered for that. Every one of them had a catastrophe. Something horrible happened and it burned their system down and they had to start over. And that's what they settled on. They turned to a white knight to get them out of trouble. And in most cases, it was the government. By the 1940s, physicians in the UK, their customers were broke. They were paying them with chickens and pigs, if anything at all. And they begged the government to take them on as employees. They begged them. We don't want to wait till it gets that bad, right?
right. I mean, like we say in our coastal, because we follow a lot of coastal policy, if we get ahead of hurricanes instead of waiting to be devastated, we could actually save a lot of lives. Well, let's go ahead. I know Kathy Kleber had a question.
I do. Thanks again, Michael. And I totally agree with you that, pharma is such a big part of this. I mean, when you see the cost changes over the last many years in terms of pharmacy, and of course, I am not a big government intervener, but I feel very, very strongly that allowing the advertisement that they have allowed and spending their money on advertisement versus spending it on research, whereas they used to spend it, I think we got a lot better. A lot more bang for our buck in terms of pharmaceuticals. And I think the pharmaceutical system is a place to tear it apart and start over and look at what we're doing and how we're doing it. And I do believe very, very strongly that we can make I mean, look, some of the other areas I think are really tough to figure out, because we don't know exactly what costs are, like you said, in hospitals and what we're paying for. But you could really make a difference if we took the pharmaceutical apart, the pharma apart and started over to figure out how to make drugs affordable for people.
I think it's interesting that you brought up advertising. You noticed that for many, many years, you didn't see any ads for liquor, for hard liquor on TV. Now, there was never a law that said hard liquor companies can't advertise. There were consumer groups that went to them and said, and church groups that went to them and said, could you just not advertise on TV, please? And they said yes. And for like 40 years, there were no liquor ads because they thought it was being a good citizen doing the right thing. Now, every magazine you opened had liquor ads all over it, and it didn't matter where else you looked, billboards at the airport, wherever, but not on TV. And that was voluntary. And I would call upon pharma to do the same thing because it's not most of the drugs that are being advertised are very low value drugs. You ever see the ad where Cyndi Lauper's dancing because she doesn't have a rash anymore? 8 grand a month, $8,000 a month to get rid of her rash. I'm just saying, it's low value drugs that catch all the ad dollars.
And like I said, it's just, I mean, when you look at the numbers, the dollars that go into those ads, again, it's dollars that used to go into research and made more drugs affordable because they spent the money on research rather than on ads, and they didn't have to up the cost the way that they're upping the cost now. Anyhow, that's my pet peeve in terms of
It's a good one.
start. That's it. Thank you.
Well, my pet
No,
peeve about that is the way that when they're listing out all the negative, the side effects of the drugs, and it's horrible list. But the people are like loving their grandkids and playing baseball. It's like, oh
Well,
my
you know,
God.
we're playing hardball now when it comes to creating formularies. Every year we have an excluded drug list. And if there are exact drugs with the exact same efficacy that cost way more, we're just not going to cover them. We're going to have a closed formulary. And if an employer wants an open formulary, he can have it, but it's going to drive his cost up, right? And then now we have about 150 very common drugs on a zero copay list. So in other words, there's 150 drugs that you can take if you have a Blue Cross card, and you'll never pay a dime to get those refilled. They'll send you 90 days at a time for nothing, because those drugs are so reasonable and are so good at what they do and are so important to managing chronic conditions like high blood pressure, high cholesterol, that it's worth it to us to provide them for free.
Yeah. It's those people with the rare diseases and with cancer and things that they do cost a lot of money. It's a tough situation. Okay, so then Cindy, I know you had your hand raised.
Yeah, it's more of a comment. What we've observed in speaking with employers, most don't understand healthcare, much less the reimbursement system. And most legislators don't understand healthcare. So that's part of the issue, in that education needs to occur.
I've got a innovative approach that an employer took on the West Coast. This was a gentleman I spoke to a couple of years ago. His employees were in Oregon, and they used to charter a bus that would drive down to the border, and people would go into Tijuana to get medications to save their plan the money, and they would cover the cost of it. Now, that was years ago. There are different approaches to that now, but
I think there are still companies sending their members to Costa Rica for hip replacements and knee replacements and stuff like that. And it's so much cheaper. They give them a week vacation on the beach, you know, fly them and a family member, do the surgery, give them a week of vacation, and come home and still do it for half the price it costs here. So, I mean, yeah, because
Maybe I should do that for my knee.
yeah.
I could use 4 joint replacements. I'll
Me
take
too.
half a year off.
Well, Dan and Michael, thank you so much for taking the time to shed some light on the complex factors influencing healthcare affordability in Louisiana and in our nation.
Sure.
You know, thinking about cost drivers and employer challenges and opportunities for collaboration across sectors is really important to understanding these issues and how we can work across sectors to make healthcare more affordable. And, you know, to everybody listening, thank you so much for joining us and being part of the discussion. And we hope you have a great rest of your day. If you're interested in these types of policy talks, check us out on Ellevate Louisiana's website, where you can learn more about our events, our policy committees, advocacy efforts, and how to join. That website is ellevatela.org, ELLEVATELA.org. If you enjoyed this episode, don't forget to subscribe, leave a review, and share it with someone who needs to hear it.